Thank you, Dr. Bodner. I hope you saw your standing ovation. Next, we welcome Dr. Rafael Perez-Escamilla, who will be discussing modifiable factors related to infant feeding. Dr. Perez-Escamilla is professor of epidemiology and public health and director of the Global Health Concentration and of the Office of Public Health Practice Health at the Yale School of Public Health. His research has led to improvements in breastfeeding protection, promotion, and support worldwide, as well as to the development, implementation, and evaluation of maternal, infant, and young child community nutrition programs globally. We welcome Dr. Perez-Escamilla.
Thank you so much, Brent, for your kind introduction, and I want to thank the organizers of this panel for the honor of inviting me to speak about one of my favorite topics. Lisa Bodnar just gave an exceptional presentation on issues related to pre-pregnancy and gestational weight gain, and moving along the life course perspective, I am going to talk about a very important aspect of infant feeding related to, of course, breastfeeding and the risk of childhood obesity. So there are several hypotheses that have been postulated to perhaps expect from a biological point of view to see a relationship between breastfeeding and a protection against childhood obesity. And these include the ability of perhaps breastfed babies to be able to better self-regulate their energy intake as a result to cues related to changes in milk composition during the feeding episode, and also in relationship to the energy density of the milk itself. Formula feeding moms are also expected to perhaps be more likely to overfeed their babies because they have more control over that aspect of the feeding process vis-a-vis breastfeeding, where the baby self-regulates the intake. Koletzko and colleagues, as it was mentioned this morning, has proposed that it is likely that higher protein concentration in infant formula may lead to higher insulin levels and to a more pro-obesity profile as a result of these major differences in the composition of breast milk and infant formula. Julie Menella gave an excellent talk today and has published extensively on the possibility that breastfed babies may be more likely to accept fruits, vegetables, and other foods that are lower in energy density as a result of their exposure to more diverse flavors in mom's milk. And last but not least, we know that any suboptimal infant feeding patterns that may lead to excessive weight gain during infancy is likely to also increase the risk of childhood obesity. So we're very lucky that there are two meta-analyses that were just very, very recently accepted and posted online by Acta Pediatrica that allow us to assess the epidemiological evidence behind first assessing the risk or protection that breastfeeding offers against the development of childhood obesity. And the first one conducted by Horta and colleagues from the Universidad Federal de Pelotas in southern Brazil updates a previous systematic review that the World Health Organization had commissioned to them, and this update looked at the literature through August 2014. They were able to identify 105 studies, so there is indeed a critical mass of evidence to review, and these studies led to 113 estimates that were presented in the systematic review. The systematic review is global in nature as it covers evidence from low, middle, and high income countries, and also did not impose restrictions in terms of the experimental or observational designs allowed into the studies included in the systematic review. I mentioned that there are 13 new publications that came out between September 2011 and August 2014, just for you to see how much interest there is in trying to come up with an answer to this very important question. It is important to recognize that the studies kind of were all over the place in terms of what they were comparing with what, how they defined different breastfeeding modalities, and whether the comparison group was actually formula-fed babies or babies who breastfed or exclusively breastfed for a shorter period of time. Also, there is a very wide range in terms of the ages at which obesity was assessed, and that is between 1 and over 20 years of age. And it is a very good situation that we have with this systematic review, the fact that they conducted meta-regression to actually see if the characteristics of the studies actually modified how this relationship behaved. To make a long story short, the pooled estimate suggests a significant reduction in the odds of a reduction of 26% of the children becoming obese later on in life if they were not breastfed or if they were breastfed for shorter periods of time. But perhaps the most interesting analysis is the one that they present with regards to the possibility that study characteristics may inform us about what may be influencing the effect size associated with this relationship. So we can first note that regardless of the study characteristic, the association was statistically significant across the board, but there were some differences with regards to effect size. With regards to age group, the size of the effect was significantly lower if they were older than 20 years of age than if they were younger when obesity was assessed. In terms of the study size, the larger the sample size included in the study, the lower the effect size detected. In terms of a year of birth, there was also some differences in terms of effect size. If the birth happened before 1980 or after 1980? Could it be related to differences in formula composition and so on? We cannot tell, but there seems to be something going on as a function of time. Regarding the strength of the study design, the strongest designs, which were the cohort studies, tended to show the smallest effect size. And in terms of when the amount of period elapsed in terms of recalling infant feeding practices, there was no effect modification as a result of that study characteristic. It is also, of course, very important to understand if there were differences in effect size as a result of not adjusting, partially adjusting, or fully adjusting for confounders, and as expected, the more adjustment that took place for confounding, the smaller the effect size that was detected. And when it comes to the setting, a high-income country versus middle or low-income countries, the effect sizes were almost identical in terms of the risk reduction. Also, it did matter in terms of how they categorized breastfeeding and which were the comparisons that they were actually doing, and the data tends to suggest that those that looked at exclusive breastfeeding tended to document the strongest protection against the risk of obesity. I have a footnote on this table in yellow because what they also did was actually to use 3 criteria to select the studies that had the highest possible quality, that were the cohort studies with a large sample size and a relatively short recall period. And as expected, the effect size actually dropped to 13% reduction in risk when they just looked at those studies, but at 95% confidence intervals confirm that the protection, it is indeed statistically significant. So the next question that one then tries to answer is, well, is there any evidence that by promoting and supporting breastfeeding through facility-based and community-based type of interventions, we can actually have an impact at preventing or reducing the risk of childhood obesity? So in the same journal, very, very recently, Giuliani and colleagues from the same group in Brazil, updated a previous systematic review all the way to 2014. And here they were not looking only at BMI or weight for height, but they were also looking at other anthropometric indicators. So they were able to identify In total, 35 studies, but only 12 studies reported BMI or weight for height. And of these studies, 10 were randomized controlled trials, and that should be a 2, and 2 were quasi-experimental. They also included high-income, middle-income, and low-income countries. The type of interventions were kind also of all over the place across studies. Some were based on facilities, some were based on peer counseling and other community level type of interventions, and some included both. The age at the anthropometric assessments was from 3 months to 8.5 years. And of these studies, the summary statistic for effect size show a small but statistically significant reduction in the risk of childhood obesity as a function of being exposed to a breastfeeding promotion, their moms being exposed to a breastfeeding promotion program. It is really a very small effect size, minus 0.06 standard units in terms of BMI, but it is indeed statistically significant. Elsa Giugliani and colleagues replicated the similar analysis as Orta and colleagues did to try to see if there was effect modification as a function of the characteristic of the study. And even though they didn't find much, we have to really look at this evidence with a lot of caution here, because there are only 12 studies. So we really cannot make very strong statements about it. But it does seem that, for example, in terms of the country where the study was done, there seems to be a higher benefit if it was a high income versus a lower income country. Also, sample size seems to drive a little bit the size of the effect here. So then the next question that I wanted to address today, given that there is reasonable epidemiological evidence suggesting a protective association between breastfeeding and lower risk of childhood obesity, and some evidence of a small but significant effect of breastfeeding promotion and support interventions on reducing this risk, I wanted to connect the dots a little bit with the presentations this morning and try to see if there may be some effect modification driven here by genomic vulnerability. So one of the first observations came along these lines came from Bayerlein and von Kries, based on their study in Bavaria that was conducted in the late in 1999 and 2002. And what they actually found is that the protection in risk against obesity was a function of the percentile of obesity in which the children fell when they compared formula-fed versus breastfed babies. And what this suggested to them was that perhaps those children with a higher vulnerability would be the ones that get the highest level of protection. And subsequent studies, such as the GenDai cohort study in Greece, have found that indeed there are alleles or genomic modifications in the FTO gene that may explain why it is possible that it is a protection that is stronger against babies, among babies who have the genetic propensity to become obese. So the white squares just show the propensity to be more likely to be obese if the AA allele is present, and that's among non-breastfed babies, but you can see that if the babies are breastfed, this risk totally disappears. So suggesting that there is indeed some genomic modification here. And in a study conducted by Alvarin and colleagues in Australia, it actually showed that among boys who had the TA or AA genotype, there was a dose-response relationship in terms of for how long they received only breast milk and the degree of protection against childhood obesity, to a point that among those boys who had this genomic propensity reflected in FTO gene alterations, 5 months, at least 5 months of what is equivalent to exclusive breastfeeding in boys led to actually not having any overweight boy in that group. So in conclusion, breastfeeding is associated with childhood obesity prevention in the general population. The effect size is indeed small, but this is not surprising given the constellation of factors that influence obesity. And there is a need for prospective studies that carefully measure exclusive breastfeeding duration. Breastfeeding protection, promotion, and support should form part of childhood obesity prevention strategies, and thankfully we have a fair number of evidence-based strategies that work at both the facility and the community level, and some that work at the macro environment, protecting the ability of moms who wish to breastfeed their babies to do so for as long as they want. In terms of research recommendations, I really think that the whole area of breastfeeding genomic propensity interaction seems a very promising venue for future epidemiological and basic mechanistic research. And also, it is very important to examine effect modification of this relationship of breastfeeding with childhood obesity risk as a function of other maternal-child life course factors, including pre-pregnancy BMI, gestational weight gain, and the timing of introduction and the type of complementary feeding. Thank you very much.